Good morning from Miami Beach. This is Dr. John Bennett for Neurosurgical TV. We have the honor of having Pascal Jabbour from Philadelphia. And we also, this transmission is being translated into Chinese by Ben Zhu and into Japanese by Takashi Kan. And I'd like to turn it over to Yuha to give Pascal a proper neurosurgery introduction. Welcome, Yuha.
Hello, everybody. Welcome, Pascal. So I take my slides, share screen. So Professor Pascal Jabbour, as we heard a little bit before this webinar, he's originally from Lebanon, like many other great neurosurgeons in USA, working now in USA. He's working at Thomas Jefferson University, and he's certainly one of the most important hybrid neurosurgeons of these times in the world. So he graduated in Beirut, Lebanon, 98, had his neurosurgical training in Beirut, University of Colorado, and Thomas Jefferson, where he made also fellowship and gained the present position and the same unit, Thomas Jefferson. How to become a good neurosurgeon? I never met a person who wanted to be a bad neurosurgeon. So there are few simple advices: train hard, learn anatomy. And in this case, you should follow the way Professor Pascal Jabbour has done and is doing. This is, you have to have role models, heroes to become an excellent neurosurgeon. Neurosurgery, levels of manual skills depend on number of repetitions and length of career. There's an old rule that with 10,000 of hours of training, you will come to the top level. And this counts all kind of activities like sports, music, and also neurosurgery. And my rule is that you have been 10,000 days in operation room, you are at the highest level of your skills. Neurosurgery has three parts: operative skills. Professor Pascal Jabbour is hybrid neurosurgeon doing both microneurosurgery and endovascular surgery. Then you have to do research to improve your knowledge and also skills in neurosurgery. There is clinical and basic neurosurgery. Usually neurosurgeons are doing clinical research. Pascal Jabbour has been teaching. He has a high number of residents and fellows and 500 publications. 80 of them are book chapters. He is very active, involved in congresses, giving lectures around the world, has given live courses, webinars, and he's also very active in neurosurgical social media, which means nowadays that you are changing the experience and your cases in neurosurgical social media. This is also fruitful, but actually you should do also what I call serious research, publishing in high-level, high-impact papers, and this is what Professor Pascal Jabbour has done. He's one of the pioneers in the treatment of retinoblastomas and also with a very new era, robotic endovascular surgery. And these are something that will certainly change the skin in endovascular surgery. You should train your best young people. They should become better than you. This is very important. Note, and my teacher, Professor Dr. Drake, was saying that if he cannot find that kind of young person who will become better, then he will wait. He or she will come, not she, in the case of Dr. Drake, who didn't like girls in neurosurgery, but in this aspect, he was totally wrong. Females are doing well in neurosurgery nowadays. So I thank you very much. Welcome to certainly excellent webinar of Professor Pascal Jabbour. Thank you, Seijeni. Kiitos.
Professor Hernesniemi, it is a very humbling introduction, especially coming from a giant, a pioneer like you. Thank you for this generous introduction. It's a great pleasure and honor to be here. So I'm going to be talking a little bit about the concept of a hybrid vascular neurosurgeon. Those are my disclosures. And one more disclosure is last time I saw Professor was in Madrid, January 2019. We had good time. This was the pre-COVID era where life was normal. I hope we're going to go back to those times. This is Thomas Jefferson Medical School in Philadelphia, and this is the Jefferson Hospital for Neuroscience, which is our subspecialty hospital dedicated for neurovascular. Beside the big hospital. This is Philadelphia. It's the birthplace of the Philly cheesesteak. If you go to Philadelphia, if you're familiar with the area, you would know that those are competitors, Geno's and Pat's. And for the last 50 years, this has been the competition. Which is the better cheesesteak, Geno or Pat's? Regardless what it is, when I look at this cheese in the sandwich, it reminds me each time I'm doing a carotid endarterectomy, it reminds me of the plaque that I'm removing. Probably this is why we have a high carotid disease in Philadelphia because of Pat's and Geno's. But anyway, we're here to treat the disease and take care of it. It's also the city of Rocky Balboa. This morning, John asked me if I ran the Rocky steps here. You know, I'm sure everyone is a fan of Rocky. Those are the Rocky steps of the Philadelphia Museum of Art. So let's talk a little bit about the title of my lecture, Philosophy of a Hybrid Neurosurgeon. What's philosophy? Philosophy is the study of general and fundamental problems concerning matters such as existence, knowledge, values, reason, mind, language, everything. And then the philosophical methods include questioning, critical discussion, and rational argument about different topics in life. And here it is, we're talking about neurovascular topics. So questioning what's the best way of treating disease is also kind of philosophical question. What about hybrid, the word hybrid? As you know, hybrid is the offspring of two plants or animals of different species or varieties, such a mule, for example. A mule is a hybrid of a donkey and a horse. And I'm choosing this example because one time I was called a mule. Somebody said, well, you're a hybrid. It's like the mule is a hybrid. So you are a mule. Well, I'm proud to be a mule. Mules have the best of both worlds. They are better than horses, and they are less obstinate than donkeys, and more intelligent than donkeys. So this is a hybrid that got the best of both worlds. Or we can look at it from a hybrid car standpoint. If you look at this BMW i8, I think it's superior than a totally electric car because it has the autonomy, and it's reliable, and it's eco-friendly and low emission as compared to a regular car. So it got the best of both worlds also. This slide would summarize it all. If we are all open-minded and if we agree on what we're seeing on this slide, that's it. This is going to be my lecture, actually. You know, there are different ways of treating the disease. We started long time ago with one way, then there been the evolution, technical evolution, and nowadays, if we agree that there are indications to use each one of those treatments, and if we are open-minded, I think we will be able to all agree on one thing, which is we are all here to treat the disease. We are not here to advertise for a tool. We are here to advertise for the disease, and we should stop advertising for a tool. We have one common enemy, all of us, which is the aneurysm, and it's using all the tools available to be able to fight this, this enemy, and I think we all agree on that. Let's take, for example, brain aneurysms. Why do we treat brain aneurysms? To avoid a re-rupture in ruptured ones, to prevent a rupture, sometimes to treat the anxiety of a patient, sometimes you're enrolling in a trial. So I think it's like in every disease, there are questions to ask, which is, am I able to beat the natural history of the disease? For example, in aneurysms, the smaller the aneurysm is, the lower my complication rate should be. So really crucial to have insight of our complication rate, to know in my hand what's the risk of this technique, and to be able to weigh risks and benefits, and to be able to offer treatment for the patients. Otherwise, not because the tool is available, it means we have to use it on everyone. You know, evolution in life is going to happen regardless if we're on board or not. Even Homer had evoluted. Probably his brain didn't evolve, but his body evolved, as you can see here. Same thing in aneurysm surgery and neurovascular. It's again, it's not a competition. It's all the tools against the disease. How to choose the right tools? Sometimes we don't have an option. Sometimes it's not even a question what to choose. Like this patient that was found down with this acute subdural hematoma with a blown pupil. In this case, I didn't have time to think if I'm gonna do it endovascular or open. I didn't even have time to do an angiogram. This patient went from a CTA table directly to the OR for a clipping of a ruptured PCOM aneurysm. You see it here on CTA. That's the clip. That's the intra-op angiogram showing complete occlusion. And then we left the bone out, and then we did the cranioplasty later on and the shunt. So in this case, again, that's common sense. We're not going to take this patient that's herniating and try to treat it endovascularly. Like this patient with an intraparenchymal hemorrhage with this MCA aneurysm, same thing, from the CTA table up to the operating room. Those are cases that we shouldn't even spend 1 second thinking what way is the best way. So here the aneurysm is clipped, the aneurysm is open here, and removing temporary clip, no retraction. That's an intra-op angiogram. The bone is left out. Another case of a PCOM, large PCOM aneurysm presented with an intraparenchymal hemorrhage. Same thing, from CTA to operating room, evacuating the subdural hematoma. Same thing, retractorless surgery, temporary clipping the neck of the aneurysm, intra-op angiogram showing complete occlusion, and then keeping the bone out, then doing a cranioplasty later on. At the same time, no dogma, and I'm going to show you the opposite. And in some cases, it is feasible when the patient comes in clinically, the patient is doing fine. Like this patient where I did the angiogram because the patient was awake despite this hematoma, and the patient had an aneurysm that was amenable to coiling. And in this case, older patient, I coiled the aneurysm, and then later on I decompressed the patient, and the patient had an acceptable outcome with the cranioplasty later on. And we've published on this about coiling, then taking for hematoma evacuation. So I'm trying to show you that in selected patients, you know, both ways are good, as long as there's no dogma in there and you treat every patient as a single case. This is a patient with a Initially, they thought he had a tumor. Luckily, they didn't do a stereotactic biopsy. And if you look at it, you realize that's a hematoma, and that's some flow here. So here is the angiogram showing the part that's filling. As you know, this is a giant partially thrombosed ICA bifurcation aneurysm. This aneurysm is all the way that big, and we're seeing only the part that's filling. This is a piece of rock here. There's no endovascular option here. The patient needs a decompression. We need to go in, flatten the aneurysm, open the dome of the aneurysm to be able to treat this patient. And this is, in this case, you know, I'm trapping the aneurysm, dissecting ICA, A1, and MCA. That's the giant aneurysm here. It's like a piece of rock. As you know, you're not able to simply clip it because you need to open the aneurysm, evacuate the clot. And in this case, here it is. I am trapping the aneurysm by putting temporary clips on the ICA, MCA, and A1. As you know, I can't trap it for a long time. So as long as I have dissected those areas and I'm ready to put temporary clipping, I'm going to start working without temporary clipping. I removed my temporary clipping here, and I'm going to start evacuating the aneurysm until I'm going to hit the true lumen. I'm going to have some bleeding at that time. I will trap again my aneurysm. I do those under neurophysiologic monitoring. And once I hit true lumen and I have bleeding coming out, at that time, I have already dissected my ICA, A1, M1, and I'm going to start working 5 minutes on, 5 minutes off. The 5 minutes on, I'm going to be removing clots. 5 minutes off, I'm going to clip the opening of the aneurysm and then remove my temporary clip to reperfuse the brain. And here you're going to see the clot starts to be red, and we're going to hit true lumen here. And here it is, temporary clipping is placed. And then now I'm clipping the hole on the aneurysm to be able to release temporary clipping for 10 minutes, then go back and do what I need to do. And then at the end, after I evacuated the clot, I'm able to flatten the aneurysm and clip it completely with 2 large clips. And you see the intra-op angiogram showing here. Sorry. Yeah, intra-op angiogram, so showing 2 large clips, AP and lateral, and that's the patient after the procedure. Another calcified giant left MCA aneurysms, those are, you know, challenging ones. You need to be ready to do a bypass if needed, or you need to different techniques in doing this. In this case, I did the trapping and suction decompression, where I trapped the aneurysm and with the spinal needle hooked to continuous suction, punctured the dome to be able to dissect, try to find both M2s, see if I can reconstruct and conserve the M2s. Otherwise, if I cannot, at that time, I'll be ready for a bypass and sacrificing one of the M2s. You see here how I put my spinal needle. Now the aneurysm is deflated. Now I'm dissecting. I'm able to go all the way and find the takeoff of the M2s. And then stacking my clips. This is the intra-op angiogram showing complete occlusion. Those are the clips. And then we wrote a technical note about when the clips do not fit. Those clips were too big and prominent. We had to drill a hole in the bone flap and then put a mesh on it to be able to put back the bone flap because those clips were big. What about clipping previously coiled aneurysms? This is a case of a ruptured ACOM that was coiled with good results. Then the patient came back with a recurrence. We have a manuscript under review now about how clipping is the best treatment of recurring previously coiled ACOMs. In my experience, we can start by coiling a ruptured ACOM, but as soon as it recurs, I think clipping would be the best option. This is cases of, as you see the coils that are like in the subarachnoid space. This is how they usually look like. Whenever you go to clip an aneurysm, the coils had eroded the dome. You see hemosider in here, and then the aneurysm is clipped. This is a case where we had to remove, sorry for the quality of the video, we had to remove a stent. We did an arteriotomy of the vessel. We removed the stent, then closed back the vessel, and then the aneurysm was clipped. Another case of a recurring pericallosal aneurysm. As you see the coils, they are practically in the subarachnoid space. And you really need to have enough neck to be able to clip. And we showed how the risk increases significantly once we have to remove coils. Now, if you have to do it, you have to do it. But this is an ICG green. This is a paper we published on clipping previously coiled aneurysms, and we showed that the risks would increase when you have to remove coils. In general, if you have to remove coils to be able to clip aneurysms, in general, means those aneurysms don't need retreatment. And if you have an enough big recurrence that you need to clip it, at that time you have room to do what you need to do without removing the coils. Saying this, in some cases you have to remove the coils, you don't have an option, but you should know that this would increase the risk of the treatment. Clipping a previously webbed aneurysm. As you know, the web device more and more is being used for bifurcating aneurysms. I've clipped now 5 web recurrences. The web actually can be crushed. It's easy to go with a clip and crush the web. It's not like coils where you cannot close the clip. You see here the web device, and here I'm clipping the neck. And actually the web can be deflated with the clip. It's in the 5 cases I've done, it hasn't been an issue. This is the initial case where I placed the web with the stasis. This is the recurrence at the neck. That's the PCOM. And this is after I clipped it, intra-op angiogram. My answer to people saying you cannot do both, I have an answer to both sides of the spectrum. There are some neurosurgeons that say hybrid neurosurgeons cannot do open surgery. This is a paper we've published about, we looked at the Medicare database on aneurysms that were clipped by hybrid neurosurgeons and by only open neurosurgeons in the US. And we looked at the 1-year mortality, at 30-day readmission, discharge to rehab, and length of stay. There was no difference. The only thing that mattered was the number of cases the operator is doing. So if you are a hybrid neurosurgeon and you clip a good amount of aneurysms per year, there's no reason you cannot clip aneurysms. If you're not a hybrid neurosurgeon, just an open neurosurgeon, and you only clip, let's say, 5 to 10 aneurysms a year, it doesn't matter if you're just an open neurosurgeon, you're not doing enough cases. So what matters mostly is how busy is your center and how many cases you are doing. Let's move to a different topic, like basilar tip aneurysms. This was a topic of debate. It's still a topic of debate with my colleague open surgeons. I truly believe that posterior circulation aneurysms, the majority of them, not all of them, are being treated endovascularly. This is a 235 cases of basilar tip aneurysms treated our series endovascularly. There are so many ways of treating them. Y stent, T stent, with good outcomes. My answer to people saying you can do both from an endovascular standpoint, because we have our neuroradiology colleagues that sometimes say, well, a hybrid neurosurgeon cannot do endovascular. We wrote the same paper, we looked at the same data, but we looked at aneurysms that were treated by hybrid neurosurgeons endovascularly and by non-hybrid neurosurgeon, just interventional neuroradiologist and neurologist. And same thing, 1-year mortality, 30-day admission, readmission, discharge to rehab, everything. There was no difference with that. So you can perfectly you know, treat both if you are a hybrid. What matters mostly, as I said, is how busy is your center and how many cases you're doing. And again, very important, as I said, to have the insight and to really auto-criticize yourself and look at your complication rate and look at this technique. I mean, a technique has different complication rate in different hands, and you know, you cannot apply this on everyone. Now, what's disruptive innovation? You know, disruptive innovation is the word that was used first by a professor of business at Harvard School of Business. And it describes the process by which a product emerges into an existing market, typically from outside established market leaders, and then relentlessly displaces established competitors. Disruptive innovation applies perfectly to our neurovascular world. I mean, with all the technological advancements that's happening, with all the endovascular techniques, there is definitely, we are witnessing every day some disruptive innovation in neurovascular. This disruptive innovation is not only in endovascular, it's also in open vascular, and it's happening everywhere. So very important to be open-minded. Let's look at aneurysms and the classical way of treating aneurysms. Endovascular, it used to be coiling, and now we rarely coil, less and less, with all the techniques that came in. So with coiling, you were stuffing the aneurysm as much as you can and pushing coils until you have a coil herniating in the parent vessel or until the aneurysm rupture. And what happened after that? There was one disruptive innovation, which is flow diversion. And, you know, as you know, flow diversion came in, and then that's a flow diverter being placed. And then now you see the contrast, how it's waving inside the aneurysm. And this is in vitro, for example. This is an aneurysm, and this is the coefficient of washout of contrast from the aneurysm. With no flow diverter, you see the contrast come in and comes out. And then with the flow diversion, you see the difference in the curve in the coefficient of washout, and you see here the waving of contrast in the aneurysm. And this is practically what the flow diversion does. It creates this stasis. The vessel will get remodeled, and the aneurysm will thrombose. And you've all seen, I'm not going to show you cases of pre and post, and you know, this techniques works, but we had to learn, and after 500 pipeline, we've learned a lot. And that definitely, to start with, there is a learning curve. This is at the beginning of the flow diverter era, where we looked at our series and we divided our cases through phase 1, phase 2, phase 3, and definitely the complication rate decreased. So there is a learning curve like everything else. We learned a lot of things like P2Y12 and dual antiplatelet therapy, and when to do a case and when not to do a case, and those things we didn't know. At the beginning of flow diverter, there were a lot of complications, and we had to acknowledge those complications to be able to look back and examine every step and see why we're having this. And we realized, like the P2Y12, that, you know, there are some numbers, extreme numbers, where if the patient is a hyper responder, this is associated with hemorrhagic complication. To the opposite, it can be associated with ischemic complication. And we learned this the hard way. We didn't know that at the beginning. We compared, you know, flow diverter with stent-assisted coiling in small aneurysms, and then there was the premier trial that led to the approval of flow diverter for smaller aneurysms, and they are not off-label anymore. What about the fate of the ophthalmic artery when you cover it? And again, at the beginning, people were doing 1, 2, 3 telescoping pipeline, and we realized that this can cause an increased risk of perforatous thrombosis. And there are some perforators that you shouldn't be covering with multiple pipelines, like anterior choroidal, ophthalmic artery, etc. There are some cases where pipeline and flow diverter is the best option to have. This is, for example, a case where a patient presented with a dissecting M2 aneurysm. and then was treated with pipeline with a good result. This is a case that had a clipping and wrap clipping of an MCA complex aneurysm 10 years ago, came in with this recurrence. It's a left-sided. In this case, you know, it would be a difficult to go and challenging to go in and undo all the wrapping and redo surgery. In this case, I placed a pipeline and we had an adequate outcome, an acceptable outcome with the less complication rate possible for the patient. And I think if I had done a redo craniotomy and removing all this wrapping and clipping, it would have been worse for the patient. Again, I'm not advocating to treat every MCA with a pipeline. To the opposite, I rarely treat an MCA with pipeline. I don't do that unless there's no better option. This is another case where I think pipeline was the best option. Some pipelines and coils, and the patient did well. Another distal fusiform aneurysm. This is a P2, P3 aneurysm that same thing. I treated with pipeline, complete remodeling of the vessel. Some distal pica aneurysms with complete remodeling. We actually published our papers on flow diverter for pica aneurysms and for distal cerebral aneurysms. In cases where you don't have a better option, I think that's a good option. This is a case of a transcirculation pipeline where the patient came in with a dissection near occlusion of the carotid. We needed to treat an aneurysm. So we went transcirculation from the other side through the ACOM and we placed the pipeline retrograde. The patient did well. What about pipeline for ruptured aneurysms? Again, this is challenging. You have to give dual antiplatelet therapy for patients with ruptured aneurysms, unsecure aneurysms. Patients may need a ventric, may need a shunt. So we are aware of all of that. That's why this is a high-risk procedure. That's why I'm not advocating to use that. But there are some selected cases where pipeline is the right answer or flow diversion is the right answer. For example, this dissecting VB junction aneurysm that I treated with 2 telescoping pipeline. This is another case of a subarachnoid hemorrhage. The CAT scan will show you something here. This is a fully calcified MCA aneurysm. And we all know those are really challenging cases. You go sometimes and you break the calcification. You hear the crack when you put the clip and you put another booster clip, or you take a Kelly and crank the aneurysm. This is a hit or miss, because if you break a calcification and an atheroma and it goes in the M1, that's it. You shut it down, or it flies in one of the M2. So that's a high risk open case. This is the first angiogram I did on this patient. I didn't see anything much. In those cases, absolutely to repeat the angiogram. I repeated it 4 days later, and then I see a double density here, and on the 3D I see some filling. So in this case, I did a pipeline just in the M1, and this is the long, you see here, the calcified aneurysm, and this is the long, here it is, the 1-year follow-up showing complete remodeling of the vessel, and the patient was doing fine. In my opinion, in my hands, that was the best option for this patient. Another case of a ruptured proximal pica aneurysm. What are our options here? Well, the open surgical option, I don't think we can reconstruct this. I think it's to shut down, do a pica to pica bypass, shut down this vessel proximally. Again, that's an option. It's a great option. Another option is flow diversion, as you see here. The small flow diverter, just short and small in the pica, showing initial stasis of contrast, and then on follow-up, complete remodeling of the vessel on follow-up. Here it is. That's the most recent follow-up on that, showing that the pica is patent and completely remodeled. Another case of a subarachnoid hemorrhage from a blister mid-basilar aneurysm. I know that as open surgical option here, I mean, there are few here, because you're gonna go in, as you know, in those blister mid-basilar aneurysms, you go in and here it is. The basilar is like just open in front of you. Here it is. You know, at this point, I thought that flow diversion would be the best option here, and this is the 1-year follow-up showing complete remodeling of the ruptured basilar aneurysm. So treating blister-like aneurysm with flow diversion is absolutely a good option. What about shunting in those ruptured cases? Yes, it is a challenge, and yes, there is a slight increase of hemorrhagic complication. We do in those cases a technique for shunting where we would we are very aggressive placing ventricles as soon as the patient come in, so we don't have to place it after the patient is on dual antiplatelet therapy. Then when we want to shunt the patient, we would do a soft pass. So we would in the same area open, remove the ventricle and soft pass the catheter, and then take it and tunnelize it and do a shunt. It is not associated with increased risk of infection. This is a series of 500 cases we've published showing that it is an acceptable option. Patient satisfaction, patient selection is key. This is a mistake, a judgment mistake from my part. Patient came in with this unruptured A1 aneurysm. In this case, I could easily go in and clip this aneurysm. I could have done a stent-assisted coiling if I want. So in this case, I said, I'm going to place a flow diverter in the A1 and take care of it. Well, this was the old pipeline where you couldn't resheath it. So I ended up placing a pipeline, but the pipeline was too long, and then I ended it here. Well, big mistake, again, because I jailed the M1. I know in a lot of presentations, you see people jailing M1s and M2s, and they say it gets remodeled. That's not the right thing to do. We should never jail a big vessel like this. So again, great result. The aneurysm is gone. But if you look a little bit better on this angiogram, and this is a month later, the patient came back, you see something here. What's that? That's thrombus distal to the pipeline. So what happened here? I shut my route to go and do even a mechanical thrombectomy, right? Because I have my pipeline going from here all the way to the A1. I have stasis of contrast and flow here that led to this thrombus. So you see the CT perfusion showing decreased perfusion on that side. So this patient ended up being admitted to the ICU. Thankfully, he didn't have a major stroke. He had a small stroke in the internal capsule. He ended up recovering with some residual deficit, but then, you know, we kept his blood pressure up. We kept the patient hydrated. We stopped his blood pressure medication. He ended up later on doing a good autoregulation. But again, this was a judgment mistake from my part, and I would never do this again. This is a case where I still don't know what would be the best option. This is a young patient that had a previous surgery of a clip wrapping of this aneurysm that was small. It was a ballooning of the ICA bifurcation of the ICA before it bifurcates. 25-year-old patient had this previously, then presented with increased headaches and increase in size of the aneurysm. So this is a case, same thing, left-sided hemisphere. The patient had already surgery. You see the titanium mini plate here, where my option was to go in and do a redo surgery, try to treat this aneurysm, or I thought I would place a pipeline from MCA to ICA. I went and decided to place a pipeline after discussing all options, and the procedure went well. It took 20 minutes, and 24 hours later, the patient became aphasic and hemiparetic, and that's what we have, those distal intraparenchymal hemorrhages described with pipeline. Again, I did an angiogram. There's stasis of contrast in the aneurysm. I cannot do better acutely. It was a challenge to manage Plavix and aspirin because now we have a fresh pipeline. We have an intraparenchymal hemorrhage. The patient needs to stay on Plavix and baby aspirin, but we need to be careful. So in this case, I drove the P2Y12 really up high, but not too high to be able to be in between for this hemorrhage and for the pipeline not to thrombose it. 6 months later, I have a good angiographic result. There is some filling here, but it looks good. The patient had recovered his speech, but was still hemiparetic on the right side with spasticity, but able to ambulate. So this was a challenging one. What about aneurysms with persistent filling and after failed treatment? We looked into that. There are some cases that have still persisted filling. Those are older patients, prior stent placement, fusiform aneurysms, MCA and distal aneurysms, side branches. If the side branch is coming off the aneurysm, for example, fetal PCOM, patients that had coiling with the pipeline versus no coiling. And again, as long as we look and we see, and we looked at our data, and when we see data like this, we learn that those patients should not be treated, for example, with pipeline. The good thing is with pipeline, once the aneurysm is gone, it's gone for good. And we demonstrated this in this paper, where if at 6 months on angiogram you have 100% occluded, that's it. It's occluded, it's never coming back. And it's hard to say this about different endovascular techniques, because in coiling you cannot say this, in web you cannot say this because you still have, even with 100% occluded at 6 months, you still have risk of recurrence later on. But in flow diversion, you don't. This is our most recent paper on 598 patients treated, and we try to look at predictors of complication. So delayed aneurysm rupture is associated with increased aneurysm size here, more than 25 millimeter. It is increased with aneurysms of the posterior circulation and previous history of subarachnoid hemorrhage. What about distal intraparenchymal hemorrhage? It is associated with numbers of pipelines used. That's why we try not to do telescoping pipelines. And we found that it is associated with the P2Y12 patients that are hyper responders to Plavix or other antiplatelet. And again, multiple other risk factors. Where all the techniques fail and where we thought that flow diversion would be the answer, it's not the answer. This is a case of a patient with this partially thrombosed aneurysm that had coiling at an outside facility, then recurred, then had multiple stent-assisted coiling, and this became a beast. And as you know, those are beasts. I think at this point, dolichoectatic, giant partially thrombosed posterior circulation aneurysm, we really don't have the right answer. Either open or endovascular, we don't have the right answer. I think in those cases, the only thing that proved maybe to be safer is just baby aspirin. So in this case, the pipeline had just been approved. This is an old case of mine, and this patient had been all over being treated. So the patient came to me and said, well, I have the answer for you. We have a new device called pipeline. And you see the problem in those cases is the mass effect associated with. So look at this mass effect of thrombus in the brainstem. In this case, in those cases where you know that the patient is going to develop hydrocephalus and you're going to treat the patient with pipeline, I would recommend to shunt those patients first, because you have a small window where you can shunt the patient before doing the pipeline and starting a dual antiplatelet. And this is what we do now in cases where we think the patient's going to develop hydrocephalus. In these cases, we didn't shunt the patient. So we placed the pipeline. Patient 2 weeks later developed hydrocephalus. I had to do a small window for the antiplatelet, dual antiplatelet therapy to shunt the patient. What happened? The patient developed thrombus inside the pipeline. I had to go do a mechanical thrombectomy and open it again. And then later on, I mean, this is the result. Well, again, we're not treating a picture, we're treating a patient. We look at this result like, well, great result, look at this remodeling. Well, great for the picture, but not great for the patient. The patient ended up slowly deteriorating, needing a tracheostomy and a feeding tube, and then the patient ended up 6 months later slowly dying, because the problem here was mass effect, not just having a perfect picture on an angiogram. More and more you're seeing the web device. This is mainly for bifurcating aneurysms. You see the stasis of contrast here, and this is a 6 months follow-up showing complete occlusion. So this is new, and this is from our paper that's going to come out in Journal of Neurosurgery. Sizing is key in those cases where you really need to oversize the device to hug the wall. This is from the Webbed trial, as you see, before and after, before and after. You see here an MCA aneurysm before and after on 3D. So this is a large MCA, same thing, before and after. So basilar tip. So again, some results with the web. Again, long-term results, we're still not sure about this long-term. We've seen patients coming at 1-2 years with a recurrence. I have a patient from the Webbed trial, came in after 5 years with a recurrence, and I had to stent-assist coil the aneurysm. This is something talking about what's the difference between adequate occlusion and complete occlusion. Here we're starting to change definition about what's adequate, what's complete. Do you accept adequate occlusion with a tiny neck? Anyway, another flow diverter, the FRED, this is a case of a patient with a dissecting large aneurysm at the neck, presenting with crescendo TIAs and strokes despite full medical treatment, dual antiplatelet therapy, decided to treat this patient with a FRED device in the neck to try to shut down the flow from those thrombotic and thromboembolic events going up to the brain. This is the stasis of contrast after the FRED is deployed. And this is a 6 months follow-up showing that the carotid is completely remodeled. There is some flow here, but definitely we shut down the way for thromboembolic events. This is the 3D Dyna CT showing the FRED device all the way up. It's like a DNA braids. And in my mind, this is the best, treatment for this patient. Again, same thing. This is a case where we really use the combined open and endovascular technique. This is a patient that came in with a type D carotid cavernous fistula. And as you see here, couldn't go. Here it is. You see the fistula. There's no IPS, couldn't go from inferior petrosal sinus, IJ IPS, to get to the cavernous sinus to treat it. The patient didn't have any dilated SOV for me to be able to go there and treat it. As you know, in carotid cavernous fistulas, you need to get to the cavernous sinus to shut them down. So those are the ways of going to the cavernous sinus. You can go transvenous, IJ, IPS, cavernous sinus. Sometimes you have the facial vein. You go through the facial vein. You loop and go in the SOV cavernous sinus. In this case, if you see here, the fistula is being drained all the way directly with cortical venous drainage to the superficial sylvian veins on the right side. So it would be a good option to catheterize the superficial sylvian vein with a microcatheter, go in all the way to the cavernous sinus and shut down the spout. So that's what I did. I did an image-guided burr hole on the superficial arterialized sylvian veins and put a catheter in them. That's the patient, that's the burr hole. Those are the arterialized superficial sylvian veins. And then I am catheterizing it with a small angiocath, and I'm pushing my microcatheter all the way from those superficial sylvian vein all the way down to the fistula. It's a straight shot. And then I'm gonna inject my liquid embolic there. This is done in the hybrid room. And here it is, my microcatheter going all the way to the fistulous point. And then I'm gonna inject my liquid embolic, the onyx. And at the end, I'm gonna remove my microcatheter and I'm gonna put some gel foam, some pressure, and then a burr hole cover, and then shut it down. So here it is, the cast of onyx, as you see it. The fistula is completely shut down. I'm pulling back the microcatheter, and this is a piece of gel foam on the vein for 5 minutes, no more bleeding. I keep it there. I put a burr hole cover, and then we publish this as a technical note. Lenticulo striate ruptured aneurysms, those are challenging ones, mainly in moya-moya. Patients can present with an aneurysm from a lenticulo striate collateral of moya-moya. Those are dangerous aneurysms. They can rupture. That's one of those cases. And here I'm showing you both ways. You know, that's a case with moya-moya. That's the aneurysm. That's a nasty aneurysm. And I was able to catheterize this tiny vessel. The patient came in already hemiplegic with a big hemorrhage. I was able to catheterize distally and shut it down with liquid embolic. That's the aneurysm. And in cases where you cannot do that, again, I mean, you have a hematoma dissecting the internal capsule. You go in. That's a case of a hemorrhage from a moya-moya lenticulostriate aneurysm. You see here the vessels en passage. I was able to microcatheterize it, but if I'm going to shut it down with liquid embolic, I'm going to shut down everything, and there are vessels en passage. So I decided not to do that. So dissected the sylvian fissure, went transinsular, opened the area that was the most superficial at the hematoma, followed the wall, because with image guidance, I know where my aneurysm was. So you see here, I'm getting to the hematoma. Here's the hematoma. I'm gonna follow this lenticulo striate dilated moya collateral. I'm gonna get, here it is. I'm gonna get to the aneurysm, and then I'm gonna be able to clip it distally and keep the rest of the vessels en passage. Here it is. And that's the intra-op angiogram showing that the aneurysm is completely clipped. And actually, the patient ended up doing not so bad at 6 months. She was moving her right side and was doing well. As you know, in endovascular, the transradial approach has been had a big hype recently. This is actually before all this came up. We published this thinking outside the groin, if you want, or thinking outside the box. This was in 2016, where we looked at alternative access for endovascular treatment. We looked at transradial, we looked at carotid cut down, carotid puncture, SOV, all of that, where, you know, difficult arches, where we did strokes, transradial. So nowadays you see a lot of it. And again, it's a learning curve. This is we recently published this about our first 760 neurointervention using the upper extremity. It's definitely safer. It's definitely has a better patient satisfaction. Patients can go home much earlier for diagnostic angiograms. You can sit up the patient in, right away after a stroke or after an aneurysm endovascular treatment instead of keeping them flat for 4 to 6 hours. And definitely it has a learning curve. So we looked at fluoroscopy time, and it looked like it took at least 14 procedures to have a stable fluoroscopy time as compared to transfemoral. This is our book that I collaborated on with Eric Peterson from Miami. It's the first radial access for neurointervention that's gonna come out soon. The e-version of it is already out. So let's move to stroke. And this is a lecture I give. I call it Stroke is a Surgical Disease. Sometimes it pisses off a lot of people, but absolutely, stroke became a surgical disease. I think long time ago, there was nothing we could do about stroke other than antiplatelet therapy. Nowadays, there are a lot of things we can do about it. This is the case of a basilar thrombosis from a dissection of the vert. Patient presented with locked-in syndrome, and as you see here, going up with a microcatheter and suctioning, and that's the result. And you see here the clot that we aspirated. That's really a large clot. So definitely stroke became a surgical disease nowadays, and that's the MRI. Never leave any large vessel occlusion behind. This is the case with the patient with tough arch, with the aortic aneurysm, couldn't go transradial, couldn't go transfemoral. The patient had an M1 occlusion. Well, what's the other option is carotid cut down. I didn't do a carotid puncture because the patient had IVTPA. I thought with the carotid cut down, I have more control. So it took 10 minutes to open and expose the common carotid. I'm putting the purse string around the common carotid, and then I'm putting my catheter there, and then my devices to go up, open the M1. Very important to be aggressive. You need to find a way. If you don't open the vessel, the patient's gonna do bad. So again, this is something we say, never leave an LVO behind. And here it is. I deployed my stent retriever, and then at the end, I tie down the purse string while someone is removing the sheath, and then I'll close the neck. Carotid puncture is an option. It has a higher risk of bleeding at the end because you can't put pressure on it. So definitely if the patient had IVTPA, I'd rather do a controlled environment and a carotid cut down instead of a carotid puncture. This is the technical note. We wrote about it. This is an interesting case of bilateral simultaneous mechanical thrombectomy we've done on a lady. Very interesting case because the lady was at an outside hospital, suddenly became quadriplegic from the neck down. No one would think, oh, that's a stroke. She became quadriplegic. They thought there's something in her cervical spine. They came in, they start imaging the cervical spine, MRIs, they couldn't find anything. Turned out the lady had bilateral MCA occlusions, as you see here. We went simultaneously with both groins, and we opened simultaneously because we didn't want to waste time. So we were 2 operators. We went with 2 catheters, simultaneously opened to open it quickly. And they actually talked about her in the news.
Something that many doctors have never seen. Health reporter Stephanie Stahl is here with an incredible story of survival.
That's right. This is really incredible, guys. This is a testament to the importance of quick intervention when dealing with a stroke. But this is also a love story sprinkled with a big dose of luck.
Can you put both arms up for me like this?
Something so basic, but moving had been impossible for Debbie O'Neill. This busy Langhorne grandmother who loved traveling was suddenly paralyzed one night in early June.
The first night is like getting hit in the face with a sledgehammer.
Debbie had a stroke on both sides of her brain. Doctors explained to her husband it was a situation they'd never seen before.
It just doesn't look good. There's nothing really we can do for here.
But fate quickly turned in their favor. Debbie was flown to Jefferson, where Dr. Pascal Chabour performed a mechanical thrombectomy.
This was very critical because the results would have been devastating.
It was the first time Dr. Chabour ever treated this kind of stroke that caused a double blockage in the brain. He used something called a stent retriever.
Anyway, so again, and then we're not going to take away from the satisfaction of pulling a plaque. Again, I'm able to do an endarterectomy, I'm able to do a stent, but that's nothing compares to the satisfaction of pulling a plaque like this. But there are, indications, and definitely I'm not going to do an endarterectomy on a patient that had radiation at the neck or a previous endarterectomy. So again, those are things to think about and do it. Now, not all the strokes are arterial. More and more with COVID, we've seen venous. This is a patient with pan-sinus thrombosis presented, where we went in the sinus and did the mechanical thrombectomy. Those patients can be very sick when all the sinuses are shut down. And we use a device that's usually for our peripheral vascular colleagues. It's called an angiojet. And this is the clots that we remove from sinus. Sinuses are huge. They can contain a lot of clots. That's the device. They use it for peripheral vascular. It's a high pressure jet of fluid that goes in from one hole and comes back from the other. So that's it. And more, we're doing transvenous all from the upper extremity. This is a case of arterial from the radial, transvenous from the cephalic vein. And we're not using the femoral vein anymore. So we'll go up cephalic vein all the way and get to the IJ. So I think it's about time for neurosurgeons to be stroke specialists. As I showed you, we have so many strokes. They're gonna be and we're gonna expect to have more than 1.2 million strokes a year in the US in the coming 5 years. We don't have enough people taking care of stroke. This is a paper where I did a comparison of 2 stroke cohorts that were cared for by 2 different specialties at Jefferson. Because at Jefferson neurosurgeons, we also give IVTPA. So we are involved in strokes, and we are on call with us, and we divided with the neurologists. So because also some people would say neurosurgeons cannot take care of medical strokes. Well, so I looked at the medical patients that didn't have mechanical thrombectomy. We divided them into a cohort that was cared for by neurosurgeons and cohort cared for by stroke neurologists. And at Jefferson, the outcome was the same. There was no difference in outcome in those patients. So we are definitely capable of taking care from a medical standpoint of a stroke. Again, if it's too late for a thrombectomy, it's very important to be aggressive in doing decompressive hemicraniectomies. You can't imagine how many times I see patients transferred from outside hospital where, neurosurgeon said, oh, there's no data behind it, or there is data behind it. Decompressive hemicraniectomies on young patients with stroke, it's a lifesaver. You can save lives. This is very important to do it early, very important to do it before the patient deteriorates or blow a pupil. And that has been demonstrated in multiple papers that doing it early is key. You don't want to wait until you have herniation happening. It's as you know, quick, straightforward procedure, big decompression. Make sure you make a big one, not a small one, and the brain will mushroom out. And then it is a life-saving procedure. So What's the ultimate emergency in our business in endovascular? Well, it's not stroke, it's not aneurysm, it's actually carotid blowouts. And we have a busy ENT department here. They take care of a lot of ENT, head and neck cancer. And you can't imagine how many of those patients come in with carotid blowout. This is a case where you have patients being transfused, multiple liters of blood. They bring you the patient to the INR with the doctors and ENT doctors pressing on the neck. Blood is everywhere. So this is definitely very hard disease to treat, but important to know what to do in those cases. This is a lady that was bleeding from everywhere, and look at the run, extravasating in her oropharynx. I injected liquid embolic, she kept on bleeding, and then I had to place an off-label covered stent. This is a bronchial stent. It's off-label that would shut down the hole, and that's the off-label stent. So you need to think outside the box. You need to have, because we don't have in neuro on-label stents that are covered. It doesn't exist. Oops. Let me go back again. So yeah, so this is how it looks like. You see the onyx here, you see everything, and this saved the life of the patient, and this stopped the bleeding right away. The majority of those patients are cured from their cancer. They present with this because of the delayed radiation effect. So we're not talking about someone with an end-stage cancer of the neck. We're talking about someone cured from the disease, but having a complication, long-term complication of radiation. Another, so again, maybe we're not doing a lot of bypasses for aneurysms anymore with all the flow diverted, but definitely there are still indications for carotid occlusions, refractory to medical treatment, moya. This is the case actually with aspergillosis of the cavernous sinus, all the way invaded. A stent is not an answer here. A balloon angioplasty is not an answer. This patient kept on having crescendo TIAs on dual antiplatelet therapy. This patient needed flow augmentation. So this is a case where I did a bypass, and the patient never had any TIA symptoms anymore. Again, I don't do as many as BIN. No one in the world does as many as BIN. Bypasses, but if it's needed, you know, we need to keep the skills, and we are training residents, and they need to be able to do bypasses if needed. So that we should not make of this a dying art. This shouldn't be a dying art, like clipping aneurysms, like resecting AVMs, clipping fistulas. So you know, if you are a vascular neurosurgeon, you should be able to do it all. Otherwise, you cannot be a complete vascular neurosurgeon. And this is at the end, and this is the ICG green. And then I like to do 3D CTAs showing the bypass going in, patent bypass going in all the way. Another case of, another case of bypass for moya. Patient came in, this is a patient came in 8 years later, and then showing the patency of the bypass. You can follow it here with MRAs. I mean, nothing compares to this beating artery that you see once you know you dissect it. Telemedicine, we started using telemedicine way before COVID, and this is in 2009 when we started the Neuroscience Network, and we placed robots in all those hospitals, and this is how we built the network. And those are robots where they would consult us whenever there's a stroke patients coming to the hospital, where we would log on. And this is the robot that I'm driving with my cell phone, and I'm talking to the attending physician. They have a stroke, they log on, they upload the CAT scan, all the labs, and first question is if the patient meets criteria for TPA. Then we tell them if the patient needs to be flown to our hospital. We can follow on the app the helicopter, and from the time it leaves their hospital until it comes here, and then you can, the team is ready, everyone's ready. This is continuity of care. The helicopter is landing on top of the hospital. I already gave IV TPA to the patient. I talked to him, I talked to their family, and then I'm the one waiting for the patient to go up and do the mechanical thrombectomy. So telemedicine is really let us to do cut in the timing and be very important in increasing the TPA, patients getting IV TPA at outside hospitals. Those are papers where we looked at the outcome of our telemedicine program on those hospitals, and a lot of hospitals were able to increase their IV TPA use. They were able to become primary stroke centers just because of the telemedicine presence. As you know, stroke is a team sport. We're not able to do it alone. Those are my partners, Dr. Jumakaris, Dr. Reed. This is the whole team. So it's very important always to, work as a team. Endovascular robotic could be the prelude for remote stroke intervention. We started this just before COVID. It was exciting. We did the first transradial carotid stent robotically. This is the patient with a lot of diseases from radiation. This is the robotic arm that's close to the patient. And that's the console outside. Here I'm sitting without lead or anything. I'm driving all the instruments. You see what's happening in the room, in the corner down below. And this may be the prelude of remote stroke intervention. So patients that are in remote areas where if they're gonna make it to a hub hospital to get their mechanical thrombectomy, it's gonna be too late. In those patients where you don't have any other alternative, maybe remote stroke intervention would be the answer. It's still too early. We're not there yet, but everything starts with a dream and everything starts with ideas. And hopefully maybe in the coming 2 to 3 years, we can overcome all the challenges to be able to do that. So this is, we compared robotic assisted stenting to manual stenting, and there was no increased fluoro time, no increased contrast, and no increased complication rate. The future is now. Here I am here driving our mobile stroke unit. So we have this mobile stroke unit. It's an ambulance on steroids. So this ambulance has a remote presence capability, so I can log on. And then it has a CAT scan where you can do a CAT scan, you can do a CTA, you can do a CT perfusion. A stroke happens, they call the mobile stroke unit. The patient gets IV TPA curbside at their house. We get the CT head, we get the CTA, we're remotely connected, and then the patient is brought directly. We're all ready for the patient in the INR suite, and the patient comes directly to angio suite, not stopping to get a CAT scan or anything, because everything was done on the way in the ambulance. And we looked at the mobile stroke unit impact on our times, and it's reducing times from dispatch to scene arrival to CAT scan to teleneuro. You see here the MSU to curb to scan trending down with numbers. So, time is brain, and we're able to decrease the time with that. So another, I think someone needs to themselves.
Yeah, I'm sorry. I'll get that.
Yeah. Being an endovascular neurosurgeon opens the horizon. Neurosurgeons involved in the treatment of retinoblastoma. When I first started my residency, I never thought I would be involved in an eye disease. But yes, this is the ophthalmic artery, super selective catheterization of the ophthalmic artery. And those are babies that before this technique, they would lose their eyes. 80% of them will have enucleation. So those are really small babies. Sometimes it's challenging to get access to their arteries. And this is here, I'm going up with a small sheath, and I'm going up with only a microcatheter from the groin all the way up to the ophthalmic artery, no guide catheter or anything, to decrease the risk of injuring any vessel. So that's my microcatheter going all the way up, and then catheterizing all the way, going up blindly, catheterizing the ophthalmic artery, hooking the ostium of the ophthalmic artery. You see my microcatheter here. I'm advancing, and then you see I'm hooked in the ophthalmic artery, and this is a run, super selective run. And then I'm gonna inject the chemo, where the chemo is injected 1 cc per minute. And then at the end, I'm putting pressure at the groin by making sure that the SATs at the toe are stable. I'm not putting too much pressure. And it is actually a treatment that's changing outcomes. You see here before and after. You see the big retinoblastoma before and after, and patients are able to save eyes. It's very rewarding to see that we're changing the outcomes. Percutaneous treatment, those are cases of venolymphatic malformation of the orbit. As you see here, patient presents with proptosis, where we're able to do a ultrasound percutaneous injection of those lesions, embolize them before the ophthalmologist takes them out. You see here the needle, I'm doing an injection, make sure I'm inside the lesion, and then I'm injecting the liquid embolic. Those would have been really challenging and bloody tumors. Now it's being removed just like one block, much easier. And we published the technique of pre-op in ultrasound guided embolization. This is a carotid body tumor. Again, percutaneous, much more safer and more efficient than endovascular. I'm doing my roadmap here. And then I take a balloon inflated in the carotid to make sure that I'm not having any reflux of liquid embolic. So this is my percutaneous ultrasound puncture of the carotid body tumor. And then I'm inflating the balloon to protect the carotid from the endovascular way. And then here it is, I am injecting the liquid embolic, the onyx. And then here, that's the onyx cast. And at the end, this would be a rock that you remove safely. Here's the onyx inside, and the surgery become much straightforward. Frameless gamma knife, we just started doing this, as you know, for stereotactic radiosurgery. If you want to do it angiographically based, you always need a frame. Now, even angiographically based with a new element, which is the BrainLab software, we're able to fuse angiogram and MRA CTA, and we're able to do those cases frameless. And it's much easier on the patient to do those cases frameless. That's the fusion program. And then, as I said, we use this face mask to do it. A lot of interesting diagnoses. This is a Bow-Hunter syndrome, where I did a dynamic angiogram. As you see, when the patient turns the head, you see that the vertebral artery is completely occluded. Then the patient turns back the head and you see flow. I do a lot of dynamic angiograms. I rarely diagnose a true Bow-Hunter syndrome. In this case, it was a true Bow-Hunter syndrome. You see here, patient turned the head all the way, stasis of contrast, shut down the vessel completely. And this patient, and here it's open again. So in this case, we did a decompression and in the area of C1, C2, and relieved the symptom of the patient because the patient was passing out each time they look back. The contralateral vertebral artery ends in pica, so that's why the patient was living only on this vertebral artery. You see here how narrow it is when the patient turns the head, and then it opens up. Spinal dural AV fistulas, those are cases that are really fun to do them open, but sometimes we can embolize them. This is a case where we just clipped it. And again, being able to do both is really important. We're able to decide when to push the envelope one side or the other. As you see here, the feeder is coming from the foramen, and that's a complete cure. You go in, place the clip, and then do the intra-op angiogram, and then all the fistula is disconnected. Could I do this endovascular? Yes, I can. It depends on the anatomy and the architecture, but open surgery is straightforward. This is a technique where we use the balloon catheter to be able to push our liquid embolic distal in a spinal fistula and cure it. Innovation in open surgery, it's happening, but at a slower pace. This is our new exoscope and voice recognition robotic. So as you see here, I'm talking to the exoscope and with voice recognition.
Align to access.
So I say align to access, and the exoscope is following me. I said zoom is zoom. A lot of exciting stuff. And then I think it's time for neurosurgery to learn from the airline industry. It means double checking, triple checking always, and then do simulations, get the residents to do simulations, to do flow models. I mean, this is crucial. This is a simulation-based training that we've done for the pre-sigmoid approach for our residents, where they would drill the pre-sigmoid approach. It will record their timing, and then if they hit the facial nerve, they have a beep. If they hit the sigmoid sinus, they have a beep. And this is a good way of learning. Another, you know, flow models here and simulators, endovascular simulators. We get all the residents involved in that. And then at the end, no matter what technique you use or what device you use, it's a match between you and the device. It's very important to know each other. It's exactly like dating. You need to get to know each other, you and your device, or you and your technique. You need to anticipate the reaction to your action, right? I mean, you need to know if you're gonna do something, what's gonna be the consequences of that. You get to avoid embarrassing situations, exactly like dating and matching. And you get to know how much to ask and what to expect. And sometimes you can push to a nervous breakdown. This is when you push your device and something bad happens. And it's very important to really look and think about that. So knowledge is very complex, and there are things that we know. That's good. There are things that we know that we don't know. That's a good thing, because we need to work on those things because we know we don't know them. There are things we don't know that we know. This is a bonus, right? We know things that we don't know that we know. But the most important part is there are things we don't know that we don't know. And this is ignorance, and we are all ignorant. And we need to look for those things that we don't know to be able to work on that and improve ourselves. Try to follow the rules in general. I mean, this guy is breaking every single rule in this picture. And try to learn from our mistakes. Okay, I mean, we make mistakes. That's you know, we're humans, but definitely use this mistake to learn from it. So like this, what happened? Went in, jumped in, exactly down in the same hole where it got stuck. So I think it's about time to embrace our breed instead of fighting us, the breed of hybrid neurosurgeons. It's about time to encourage new generation to go into the specialty. I think the two pioneers, you know, Dr. Rosenwasser and Dr. Hopkins, were visionaries because they introduced the field to neurosurgeons. Look what happened to cardiac surgery. Because they kept on ignoring what's happening, there is no cardiac surgeon that's able to do an endovascular procedure. They don't do coronary stents because from the beginning, they really ignored what's happening, and there are no hybrid cardiac surgeons. So the ship has sailed long time ago, and I think we are lucky to live in this day and age of technological advancement. We should take advantage of that. I want to acknowledge all my research fellows through the years. They are all neurosurgery residents now in programs. And my current research fellows are Karim and Rawad. They are doing really great job. And then when you adopt a new technique or a new device, there are always pluses and minuses with new technology, like what's happening here.
Toyota and Lexus luxury models will come with Amazon Alexa. Alexa, turn on the AC.
Turning on AC.
Finally, a virtual assistant to help you navigate.
Alexa, where's the nearest gas station? Nearest gas station in 1.5 miles.
And to help maintain your vehicle.
Alexa, order more brake pads. Ordering new brake pads. Although maybe if you didn't stop so close to the car in front of you.
I left plenty of room.
You drive too aggressively.
If you were just quiet for 2 seconds. She'll talk to you literally the entire time you're driving.
I think you should have turned back there.
I know where I'm going!
Hi, you know why I pulled you over?
No, officer, Because we were driving 72 miles per hour in a 45-mile-per-hour zone.
Anything else I should know?
2 miles back, we rolled through a stop sign without coming to a complete stop. Also, there are illegal fireworks in the trunk.
Thank you very much.
Thank you very much, Pascal, for this amazing, very convincing lecture. I admire innovative techniques. They are all the time changing the world. And I think everybody enjoyed this wonderful lecture. So I open the discussion Thank you very much.
Thank you so much.
Thank you, Pascal. It's a really amazing presentation, and there are around 1,100 audience in the WeChat channel watched your presentation.
Oh,
yeah.
Wow.
And actually, today I also treated with ENT guys for the so-called
carotid blowout.
Yes,
Wow.
yes, carotid blowout syndrome, which is a nasal pharyngeal carcinoma case invaded into the ICA. So we do the bypass, then sacrifice ICA to prevent the blow-up syndrome. Yeah.
So this lady didn't come with a blown out. She was like going to blow out, right? You had time to do that.
Yeah. Most of them are this kind of yes, to prevent
impending blowout. Yeah.
Yes. After blow up, actually, if the patient is lucky enough, actually the survival rate is very low.
Yeah, absolutely.
And regarding the carotid body tumor, actually it's quite safe to remove it directly.
Without
it looks very dangerous. Yes, we prefer to
so this is
a
this is a controversial subject. I agree. Some people think that it's not a big deal to go in and resect it without embolization. So yeah, I mean, I have some colleagues here where they want me to embolize it before. So I agree with you. Yeah.
Thank you again.
Thank you.
Some other questions, comments? Atul, I see you here. Welcome.
Here you are.
We can hear you. Yeah.
So Pascal, I really enjoyed your lecture.
Hello, my friend.
To be a hybrid neurosurgeon and hybrid endovascular is not indeed a very easy thing. And I saw your surgical technique, which was also quite remarkable and beautiful, and I enjoyed your technique. But one question I want to ask you, just for the sake of discussion. I agree that, vascular lesions are neurosurgical things. Neurosurgeon should be handling, because the problem is of morphology and the treatment is we are treating the disease. So neurosurgeon must be handling this. Now, in this world of specialization, in this world where we are going bit by bit and one bit is taken care of by one person, don't you think, of course, if you have more hands and number of hands, it is better always. But if you spend 100% of time in surgery and 100% time in endovascular, like it is there in most other countries other than in US and maybe in Japan, and I'm not sure in China, but in most other countries, endovascular is endovascular, neurosurgery is neurosurgery. You think we might just be a little bit compromising here and there, just for the sake of discussion, okay? Nothing to put a finger on.
I always love your questions, and this is why we are here, to throw some controversy and everything. This is a very important question, and this is where everyone, brings it up, and I think, it's an important thing. I think at the end of the day, if you are in a busy center, and if you are able to be busy in both, you should be able. So at the end of the day, it's like how your numbers, how many you're doing. Like I am I'm a hybrid neurosurgeon. I clip still around 100 aneurysms a year. I clip more than somebody at another hospital who's only an open and clips 30 a year. So in this case, I'm still doing it, better. I'm busy. Now, let's say am I as good as someone who does only open and clipping 300? Theoretically, no, because he's doing more than me. But what are we gaining in this thing? I think we're gaining for the patients, like having someone who's objective, who knows where to push the envelope. Like I know where to push the envelope in open. I know where to push the envelope in endovascular. I'm not practicing a thing that if my hammer, if my tool is a hammer, everything else is a nail. I don't do that. And trying also to keep neurosurgery in that field, because we don't want to fall in the other spectrum of cardiac surgery. So what you're saying is very important. I think we should find the midway. And then I think that at the end of the days, it goes how many cases you're doing. The busiest centers, they're going to have better outcomes. That's known.
The other thing, you know, where I feel this hybrid thing will be the most useful will be in AVM surgery. You see, in AVM surgery, AVM surgeon knows exactly where he will be having problems and where he's anticipating problems. Like if this artery is deep, he will, you know, better to embolize it before you go there.
Yeah.
What do you think about AVM surgery, AVM and hybrid? I think that is one indication for me where hybrid neurosurgeon will be the most, you know, beneficial for the patient.
That's true. So I think here it's very important, again, not because we have an embolic agent and we're able to embolize, we should just embolize. And sometimes pre-op embolization will add a risk. And this is why, as you said, someone that doesn't have any surgical perspective may be embolize an AVM that doesn't need to be embolized. It would have been safer to just resect it. So absolutely, I agree with you. And in this case, you really choose what to embolize. But I know if I were doing your endovascular cases, you wouldn't want me to embolize any of them, because I know how a great surgeon you are. I've seen your movies in AVMs that are remarkable.
Thank you very much. In any case, Pascal, as I mentioned to you, I like your bow tie, but nowadays I don't see your bow ties except on TV. So best wishes to you, and I'm looking forward to how your career grows in the future. Thank you very much.
Thank you so much.
Something else? Are there any questions in chat?
Let's see. I don't see any, Yuha.
Okay, only thanks for excellent lecture. So if someone else want to comment? Question?
Dr. Lenzino, do you have a question? Oh, go ahead, Victor.
Thank you, Dr. Pascal. It was really an amazing lecture.
Thank you.
Thank you so much.
Thanks a lot. My pleasure.
Are you there, Dr. Lenzino? Perhaps not. Okay. Okay.
Okay, in this case, I know Pascal is busy. He has a busy day ahead, as I understood in discussion before lecture. So
another question, Pascal.
Yeah.
What kind of indications you can use remote control robotic interventional treatment?
Okay, right now what's FDA approved in the US is only peripheral, so carotid stent. Now, as you know, in Canada, Vitor did aneurysms. He can do that, but it's with the same robot. If they open it here, we can do it. In my opinion, I think we're increasing the risk just doing aneurysms. There's no reason, because aneurysms are never an emergency, even if they are far away. In my opinion, the future for this is acute stroke intervention in patients that are really remote. So.
Regarding the moya peripheral aneurysms.
Yes. Yeah, actually, I would like to know your opinion about those.
Yeah. Actually, most of this kind of peripheral aneurysms, you can just wait, and maybe after 3 months, you redo the DSA, you can see the aneurysms disappeared. Maybe 80% of the aneurysm can disappear. Only
Yeah.
Only some aneurysms related to the vessels.
Yeah.
We need to treat. Yeah.
True. I had some cases where hemorrhage at an outside facility then came in. Then I did a delayed angiogram. It was completely gone. I agree.
Okay. Very good. I think Dr. Pascal is busy. We get going. Thank you, everybody, for participating. Thank you for the translators and especially to Dr. Jabbour. Yuha, do we have a speaker for next week yet?
Mustafa.
Oh, Mustafa?
Now I have blackout in my mind.
I know what you mean. Okay.
Yeah.
Mustafa Baskaya.
Baskaya. Sorry, I had a blackout.
Okay.
Mustafa
Very good.
Baskaya will be next Friday. Yeah.
Okay. Excellent. Okay. Thanks everyone for coming.
Thank you very much.
Thank you, Pascal.
Okay. Thank you.
Great to see you guys.
Have a great day.
Thank you.